discuss a case that is behind the masquerade hidden in the bones. Okay, so this was a 52-year-old gentleman who presented with shortness of breath. There was no other systemic symptoms. The only medical history that he had was hypertension and seizure disorder, for which he was on medications. The past history that he had was history of renal calculi associated with AKI, which was conservatively managed 15 years back, and history of UTI 5 years ago. He had no records with him at the time of presentation. Examination, there was pallor. There was no lymphadenopathy or pedal edema. Lab investigations revealed severe anemia, hemoglobin of 5.3 gram per deciliter, and he was transfused packed red blood cells. There was leukocytosis, which was lymphocyte predominant, and normal platelet count. The renal function test was deranged with a creatinine of 13.7 milligram per cent, and he was initiated on hemodialysis. He had a non-oliguric AKI. Urine examination revealed proteinuria, leukocyturia, and hematuria. The urine culture was sterile. 24 hours urine protein was 1.6 grams in the subnephrotic range. Peripheral smear showed normocytic pneumochromic anemia and lymphocyte. In view of his past history of renal stones, CT abdomen with pelvis was done, and it showed a large expansile lytic lesion that is arising from the right iliac bone. It had a soft tissue component and chondroid calcification. The tumoral tissue extension was into the right acetabulum and the right sacral ala through the sacroiliac joint. There was soft tissue infiltration to the adjacent right gluteal muscles, right piriformis, right psoas muscle with medial displacement. There were also lytic lesions involving the thoracolumbar vertebrae. This is the X-ray of the spine and the pelvis. We can see translucent areas suggesting a lytic process, and the right iliac bone where you can see the translucent areas again. So the chest X-ray, we can see the internal jugular catheter in situ. The X-ray was otherwise normal. So the possible diagnosis that was kept in mind where one was, it could be a chondrosarcoma or an osteosarcoma with a paraneoplastic MPGN presentation, a metastatic bone disease, or a multiple myeloma. So moving on to the other labs, the C3, C4 complement levels were normal. Serum PSA was normal. The corrected calcium level was normal. In view of anemia with renal dysfunction and lytic lesions, the serum FLC assay was done, which showed elevated kappa-free light chain in the range of 4,182, and the kappa-lambda ratio was also elevated, 61.7. Serum protein electrophoresis showed M-spike 0.4, and serum immunofixation electrophoresis identified this M-spike to be IgG and lambda. So he underwent a renal biopsy. This is the LM finding, where we can see that the glomeruli capillary loops appear congested, but otherwise looking normal. There was no mesangial proliferation. Few PAS negative atypical CAS were seen. There were a significant amount of tubular atrophy. This is the silver stain, which shows silver negative atypical CAS with giant cell and mononuclear cells around it. And this slide shows the degree of, there is moderate degree of interstitial fibrosis and tubular atrophy. The congruent staining of these CAS was negative for amyloid. Immunofluorescence was negative for IgG, A, M, C3, C1q, lambda, and kappa. And in view of the high suspicion for CAS nephropathy, Brown's digestion IF was done, which highlighted the kappa CAS. Immunohistochemistry showed both kappa and lambda positive CAS, however, with more intense kappa positivity. Electron microscopy showed focal effacement of visceral epithelial cell food process, 15%. There were no electron dense deposits, no glomerular or mesangial substructures. So the renal biopsy showed light chain CAS nephropathy, mild global nephrosclerosis, moderate CTIN, and hypertensive vascular changes. This was the biopsy from the iliac bone, right iliac bone, which showed acellular eosinophilic material with minimal plasma cells and lymphocytes, not favoring the diagnosis of plasmacytoma. Congruent stain was positive for amyloid. We can see the apple green birefringence. The bone marrow trephine biopsy showed tri-lineage hematopoiesis with mild plasmacytosis less than 10%. Immunohistochemistry showed CD138 immunoreactive and no light chain restriction. The fish myeloma panel was negative. So the final diagnosis was monoclonal gammopathy of renal significance with less than 10% plasma cells and bone amyloidoma. So he was initiated on treatment with the Cybody regimen. 4 months down the lane, he's presently dialysis dependent, and repeat CT showed stable bone lesions. This is after 4 months of therapy. There was a decrease in the kappa chains and the kappa lambda ratio from 61 to 8.2. Serum protein electrophoresis also shows a decrease in the M spike. Few case series, one by Wang et al. actually shows a primary and amyloidoma involving the spine was extremely rare. Only 2 cases were reported. Primary localized amyloid deposits in the bone is unusual, and any bone can be involved. The skeletal amyloid deposits are usually associated with soft tissue mass with variable amounts of calcification. They are usually slow-growing lesions causing local destruction of the bone and soft tissue. The tumor-like appearance and behavior can make it a diagnostic challenge. Another series by William et al. Highlights the amyloidoma of the skull base, and that it shows the rarity of this. Non-specificity of imaging findings can be mistaken for chondrosarcoma. Another case series by Hegenbart from Germany showed that amyloid bone involvement leading to osteolysis is rare. Local amyloid production can be seen even in patients with systemic amyloidosis, and it can mimic lytic myeloma bone disease. So from all these case series, we could conclude that the diagnostic mimicry, that is amyloid deposits, can create osteolytic lesions on X-rays and MRI, which is indistinguishable from multiple myeloma. The pathology is basically extensive amyloid deposits with monoclonal plasma cells and giant cells located only at the margins. Mechanism is local amyloid production or extracellular deposition at the site of monoclonal light chain production. And the clinical impact is misdiagnosing amyloid bone disease as advanced can disqualify a patient for cardiac or renal transplantation. Briefly about amyloidoma, it is a rare benign tumor-like deposit of amyloid protein occurring as localized mass without systemic amyloidosis. It presents as slow-growing nodule in areas commonly like the lungs, soft tissue, or brain. It can cause symptoms through mass effect rather than systemic organ failure. Briefly about MGRS, we all know that it's a clonal proliferation of plasma cells, B or LPL cells, that produces nephrotoxic monoclonal immunoglobulins not meeting the hematologic criteria of malignancy. And the renal disease is secondary to this monoclonal gamma. MGS is not similar to MGRS. The prevalence of MGRS is much less compared to MGS, 0.3 to 1.5%. And the progression to myeloma in MGRS cases is as high as 10% per year. If untreated, the risk of progression to kidney failure is definite, and these cases do not respond well to immunosuppressive regimens, and there is high rate of recurrence after renal transplant. And this is the MGRS classification. We all know the organized and the non-organized deposit. So the 2 steps for MGRS diagnosis is to identify a monoclonal protein, be it a light chain, heavy chain, or both, and to show the exact causal association between this monoclonal protein and kidney injury by kidney biopsy. We need to look beyond the kidney. We need to do SPECT, immunofixation electrophoresis, and a serum free light chain assay. Bone marrow aspiration study should be done to assess the percentage of plasma cells, trophine biopsy, IHC to detect the CD138 reactive cells. And the other ancillary tests that we can do are the CT thorax, abdomen, pelvis with PET CT, myeloma fish panel, protease digested paraffin IF as indicated, and the rest. CD markers are for B cells, usually CD19 and CD20 positive, and plasma cells are negative for CD19 and 20, and reactive for CD38, 138. This is the normal serum protein electrophoresis, where there is no M spike in the gamma globulin region. This is the abnormal SPECT, where M spike is seen in the gamma globulin region. Immunofixation electrophoresis is more sensitive than SPECT. It can determine the type of HC and light chain, and it is done when we find an M spike on SPECT, or in a case of suspected monoclonal gammopathy with no M protein on SPECT. However, the disadvantage is it cannot quantify the M protein. Serum-free light chain assay is used in the diagnosis and follow-up of non-secretory myeloma, amyloidosis, and LCDD, and it also helps to predict the risk of progression of MGS. The normal range of kappa is to lambda ratio in absence of renal failure is 0.26 to 1.65 milligram per liter, and in renal failure, 0.3 to 3.1 milligram per liter. So when do we treat MGRS? When there is a progressive decline in GFR, proteinuria above 1 gram per day. So when you have a suspected case of MGRS, the basic test that we do is a creatine-based EGFR, urine examination to look for albuminuria, the metabolic testing that includes bicarb, phosphate, uric acid, and urine glucose levels if we suspect Fanconi syndrome. Biopsy is indicated if there is stage AKI stage 1 to 3, or if there is a progressive decline in GFR less than 60, if there is albuminuria, if there is evidence of light chain proteinuria or Fanconi syndrome. Biopsy may be deferred if the GFR is stable or if the urine analysis is blank. So treatment based on the stages of CKD. In CKD stage 1 to 3, a goal is to prevent progressive renal dysfunction. In CKD stage 4 and ESRD, we need to achieve hematologic remission, that is very good partial response or complete response. If there is a plan for renal transplant, we need to treat if there is involvement, extra renal involvement. So MGRS treatment is clone directed. If it is a plasma cell clone, you go with Cybody or add daratumumab to it. If it is a B cell or an LPL clone, rituximab can be used. If no clone is identified, either rituximab or bortezomib. So bortezomib is preferred in IgG, IgA or light chain monoclonal gammopathy. Rituximab can be considered in IgM monoclonal gammopathy. So how to assess hematologic response? Basically by DFLC. And achieving very good partial response, that is more than 90% reduction in FLC or complete remission, is associated with better kidney outcomes. And renal response is said to be good if there is 50% reduction in proteinuria and no increase in creatinine beyond 25%. Renal progression is said to occur if there is increase in 50% increase in proteinuria to more than 1 gram per day and more than 25% rise in serum creatinine. So MGRS in an ESKD patient, indication for chemotherapy is if the patient is being planned for kidney transplant or if there is extrarenal involvement such as cardiac in AL amyloidosis. So to summarize, patients with very good partial response had better survival, better renal response, and patients with renal response and hematologic response had better survival. So the take-home message for today is patients diagnosed with monoclonal gammopathy and unexplained renal dysfunction should have a renal biopsy. It's basically a team approach, nephrologist, oncologist, and a pathologist. Treatment of MGRS should be clone-directed. Post-transplant recurrence should be kept in mind, and awareness of MGRS is critical to improve outcomes. Thank you.